So good afternoon, everyone. Welcome to the Antenatal Counselling Education webinar series. I'm Eileen and I'm the Maternal Safety Improvement Lead for Health Innovation Oxford and Thames Valley. We're delighted that so many of you are interested in the session today. So this is session one, covering the BAPM framework and high-risk counselling. And the presenters, Katherine and Anda, will introduce themselves shortly. So we've disabled your cameras and your microphones. And we ask you, please, to use the Q&A function for questions related to the presentation only. And we will address those in the final 10 minutes of the session. And then please use the chat box for everything else. We have put a link to a Microsoft feedback form in the chat box, and we will repeat that link throughout the session. We are going to record this webinar, and it will be available for you after the event. So thank you very much, and over to Katherine and Anda to introduce themselves.
Hi, my name is Anda. I'm one of the advanced neonatal nurse practitioners working at Oxford Neonatal Intensive Care Unit together with Katherine. And I've been involved with Katherine for this antenatal counselling kind of workshops the last few years now. And I also do, my passion is about quality improvement and preterm optimization. So that is my background. I'll hand over to Katherine to introduce herself.
Thanks, Anda. Hi, my name is Katherine Wood. I'm one of the consultant neonatologists at Oxford. And as Anda said, over the last few years, we've been developing kind of education series on preterm antenatal counselling, which is mainly focused on a MDT workshop, which I'll give a bit more information about at the end. But we have, due to high demand, Eileen has organised these webinar series just to provide a bit of a snapshot on preterm antenatal counselling and the BAPM framework for people across the region. So Anda is going to start off the webinar by talking about the BAPM framework, and then I'll continue about the high-risk counselling. So over to you, Anda.
Yep, next slide then, thank you. So just to recap, so our webinar aims is really to give you an insight how to review and interpret the framework. We're gonna, Katherine then talk about the antenatal counselling structure of it, so why, who and how. And just to say, this is a part one, and there'll be part 2 and 3, which will be exactly the same, which will be provided by Professor Dominic Wilkinson, and he will then specifically focus on extremely high risk categories. So and that's where we're going to start. So next slide, please. So we've all been faced with this situation where there is a call from maternity assessment unit, 22 plus 4 weeks baby, estimated weight 500 grams, spontaneous rupture of membranes. Please, can neonatal team come and counsel these parents? So it's not unusual to receive this phone call, particularly if you're in level 3 units, maybe not so frequent on level 2s, but equally this would be kind of valid for everyone. So if we bear in mind that we have this background information, and if we go to the next slide, is where do we start? Where do we start this antenatal counselling approach? And the first thing to know is, do we have a framework? And yes, we do. So we have all the framework that was initially started in 2008 that really sort of like summarizes that for less than 23 weeks, the best interest was not to resuscitate these babies. The categories thereafter is maybe would be appropriate if you're born 23 to 23 plus 6. Between 24 and 25 weeks, the resuscitation should be started unless parents and clinicians consider that will be severe, the baby will be severely compromised. And over 25 weeks, it is appropriate to provide resuscitation. So it's very much gestational age related, so only gestational age is taken into account, and it's sort of like black and white, you know. So if you 22 plus 6 and then a stroke of midnight you become 23 weeks, then we will not resuscitate or any other gestation. So The new framework is updated in 2019, and that's taken into account that actually, although the ethical principles of the antenatal and sort of perinatal care for how we manage preterm babies remains the same, so best interest of the patient. But we also noted that actually across the Europe and world, there's more and more countries that offer active management for babies at lower gestations. And also the framework, as you can see, the nuances, the previous one up to 26 weeks, the new one is up to 27 weeks of gestational age. And so based that we know that preterm babies of 22 weeks have similar survival rates if active management is provided at 22 weeks is similar to 23-week gestational age. So more and more colleagues across the world are offering active management and antenatal optimization for these babies at lower gestations. And so therefore we have now moved away in new framework from gestational age boundaries alone. And what we say is more likely to use a risk assessment approach. So looking at all the antenatal risk factors and the baby and mother's risk factors, and can any of those be modified, and can the outcome for these babies be optimized? And so a decision is making about active or comfort care should be including with the consultation with the parents. And it's also the quote from there that babies over 22 plus 0 neonatal stimulation may be considered following assessment of the risks and multi-professional discussion with the parents. And that is quite key because we now emphasize that actually everyone should be involved in the decision making for these extremes of premature gestations. And also they do say that, however, if the pregnancy occurs before 22 weeks, it is not appropriate to attempt resuscitation. Let's go to next slide. So when we say I talked about that we're moving on to the risk categories. So what do we mean by risk? And again, it's defined by the RCPCH, that when we talk about extreme high risk, those are the babies who have more than 90% of a chance of either the death or severe disability. High risk category babies are those who are 50 to 90% risk of the death or severe disability, or moderate if they have less than 50% of risk of death or severe impairment. So again, it's a traffic light system and it's quite easy to interpret. And if we go to the follow-on slide. And so how do we then look at the extreme risk, these categories? And again, this is sort of nice flowchart, which will lead later on to this sort of like a flowchart form as well. We look at when we have a baby with extreme risk, is there a risk is acceptable or unacceptable outcome if the active survival management treatment is provided? And that risk needs to be taken in consultation with the parents. And maybe for some parents, having a baby with a significant disability is a okay outcome for them, but for some they be very clear and they may have past experiences and they will say actually no, for them at high risk pregnancy and therefore high risk birth, at 22 weeks, they may say actually that they do not want active management, and then they go for an agreement for palliative management plan. But equally, we need to mention that the baby may be born in better condition than we think. So I can see the arrow can flip into the active management category as well, because the babies could surprise us and they may be born in better conditions than antenatally planned. So again, if baby isn't sort of showing good signs of life and oxygenation and really strong heart rate, and the parents then decide actually I want my baby to have some management, then that is okay to provide. So again, all consultation is done with the parents in agreement and a multidisciplinary team in agreement. Similarly, for high risk categories, again, it is individual, based upon individual assessments and information by parental consent. And again, it could be also on both categories. It could flip that they're happy and want us to do the full active management. And then the BAPM guideline says that if the parents want, there is no really true evidence to say that we shouldn't do any resuscitation or some amount of resuscitation. So again, it's explaining what does this all mean in antenatal counselling session to the parents. And again, they may say actually that, you know, the risk is too high for them and they would prefer comfort management. And again, similar for moderate risk categories. So mostly for moderate risk would be generally active management. But equally, it's also important for the high and moderate risk categories to mention that these babies still can be born in very poor condition, and therefore, even if active management is provided, the babies may not survive. So it is quite important to categorize that. So let's go to the next slide and see how the risk assessment form works. So this is that's included in BAPM framework, and it assesses the risks and assesses the modifying factors and the non-modifiable factors. So we will look at the gestational age, and then obviously we can see that extremely high risk category is those at 22, 23, and then it goes to the right side of the page, that it goes to the moderate risk as with increasing gestational age. It's also the non-modified factors that we can't change is where they are within their gestational age. Are they at the beginning of the week or at the end of the week? End of the week is a little bit better. If they have a normal gestational weight, that's also better. Girls do better than boys. And if they're singletons, then their output is a little bit better. The factors that we can modify is have they had steroids given? And complete course gives you better chances than none. And also, is the baby born in hospital with a NICU on site? So level 3 neonatal unit, where they have a much vaster quantities of these extreme preterm babies birth, and therefore experience is more nuanced for these extremes of prematurity. And if not, could the mothers be transferred to level 3 unit if the time permits? So let's go to the next slide. So there we have same scenario that we had at the beginning, and we've had this little brief snapshot, and we're going to categorize where this patient sits in a risk factor strategy. So 22 plus 4 weeker, female, 500 grams, and there's spontaneous rupture of membranes. So let's go to next slide. And so we can see the X's are moving, so we randomize. So 22 plus 4, extremely high risk, but it is coming to end of the week. There's a normal weight, it's a female, singleton, they had complete course of steroids given, and she's in hospital's NICU. So actually, although she's extremely high risk, her factors are more favorable. So then she moves in more high risk category, and therefore that's how we should be providing this information to the parents. Not just saying, you know, one thing, but actually parents do like seeing this form, and they like to understand, you know, the risk, and they understand that actually if she's going, baby is improving and mum remains pregnant, the risk is decreasing. Let's go to next slide. 24 weeker, preterm rupture of membranes, 1 dose of steroids, and it's a boy, and it's 420 grams. So let's see where we categorize this baby. 24 weeks, it's right in the middle between high and moderate risk, but it is at the beginning of the week, and there's a fetal growth restriction, and it's a boy, it's a singleton, and he has incomplete course of steroids, but he's in a hospital with NICU. So this baby then is still in quite high risk category, and as you can see, we're moving closer into between kind of more 23-week gestational age. So you can see that if the baby is much more immature, and there are less favorable factors that we can't modify, the risk has increased. And, you know, and again, we don't want to take, like in previous BAPM guideline, that we just take a gestational age alone. We need to take all of the factors into account when we provide the counselling. Do we have another one? No. So this is just really the infographics that you already are familiar. Again, we do provide this when we go and counsel the parents. And again, it's important to understand how do they want this information to be received. Some parents are very happy to understand percentages. Some like 1 in 7 or 1 in 3 babies. And again, I leave usually this infographics with the parents with explanation, what does it mean, and obviously explain that actually, you know, the survival is improving with improving gestational age, and also the severe disability also is improving with improved gestational age. On the next slide, there's another calculator. I don't know if you have heard of this, but NICDH calculator, it's a tool that you can download and you can input the factors. And it gives you the information below. So it gives you, again, if you provide active treatment, what is on average survival rate, and what is average hospital stay. And then if you're not treating baby actively, then again, the survival rate for 22 weeks is about 15%, whereas if you provide active treatment, it's 37%. And again, it gives you the neurodevelopmental outcome for these gestational ages. And again, it's sometimes quite useful to write this data if parents are interested. And you can then use and play around with this calculator, inputting different gestational ages and see what information is being provided. So it is very similar to BAPM, but it's just an extra tool that you can use before you go and provide a consultation for the parents and the midwives as well, which leads now to Katherine's part of the talk about the structure of the high-risk preterm antenatal counselling. Thank you for listening.
Thanks, Anda, for that run through on the BAPM framework on interpreting the risk for extreme preterms, and therefore how you approach a consultation for preterm antenatal counselling. So in this next section of the webinar, I'm just going to run through a suggested structure for high-risk preterm antenatal counselling. And as Anda said at the beginning, Dominic in the next webinar will be doing a similar session, but for focus on extremely high-risk preterm antenatal counselling. So we know that preterm antenatal counselling is important. It is one of the most difficult conversations parents might have to have about their baby, and you're making decisions with them that are going to impact their baby's life and the rest of their lives as well. So they're really important conversations to get right. And they can be difficult, especially if you're not having these conversations all the time, if you're based in a district hospital. And they can feel like a lot of pressure to get right in order to provide parents with the correct information to allow them to make the decision that's best for them and their family. However, we can think about it as being akin to practical procedures that we do in neonatology, that they can be taught. Communication skills with the right support and resources can be taught to be delivered effectively, and therefore provide great counselling for parents and helping them to make the decisions that are right for them. So we're just going to go and run through the why, the who, the what, the when, and the how of antenatal counselling now. So why do we provide counselling for parents? Well, essentially, we want to help prepare them for an expected preterm birth. And this will help parents understand what the risks of a preterm birth would mean for their baby, and therefore what the likely outcomes may be in terms of the chance their baby would survive, but also what their future may look like in terms of chances of disabilities in the future. Also, what the outcomes may be in terms of other medical health problems that preterms may encounter during their journey. We want to discuss the possible treatment options with them for preterm babies. And if you're in a district hospital, this would include discussing about transfer to a tertiary hospital, which in some areas may be many, many miles away from where they live. We also want to let them know what they may encounter during their journey with a preterm baby, the fact that it's going to be a long stay in the neonatal unit, and they may have many ups and downs along the way. One of the really important things about the consultation is that we really want to address parents' concerns. and elicit what's important for them and what's worrying them, because doing this will help to iron out any problems that then come up in the future if this is done well in the first consultation. In high-risk counselling consultations, we want to also approach this shared decision-making. As Anda discussed, when we have a high-risk category, we want to give parents the information that they need in order to make a decision what they feel is right for their baby and for their family. And we want to be able to support parents to make that decision. So who should be providing counselling? So ideally, we want to try and provide counselling as a multidisciplinary team with a neonatal doctor or ANMP, an obstetrician and a midwife, all in the conversation at the same time. Other members of the MDT may be present as well if workload allows, including a neonatal nurse, especially if the delivery is confirmed and the nurse knows that they're going to be looking after that baby after delivery. Feeding team is also important if active management is going to be approached to help with the breastfeeding counselling and supporting early colostrum expression. In Oxford, our research team also like to be involved in counselling wherever possible in order to approach parents about the different research studies going on the neonatal unit, so parents are aware and not fully overwhelmed once they're admitted. We also want to consider support for the mother and the partner, which may include other family members or friends, and also religious leaders if that's an important factor in their lives. So multidisciplinary consultations with the neonatologist, the midwives, and the obstetricians is really important to try and achieve. This allows parents not to need to repeat difficult thoughts or concerns that they might find hard to articulate about expecting a preterm birth. If everyone's present at the same time, it allows them just to discuss that in that one scenario if they don't want to repeat it several times. Parents are not always clear about what team covers what area, and they may ask questions to a neonatologist that are obstetric related and vice versa. So if all the teams are present in these conversations, any questions the parents have can be answered by the relevant team member. The plan can then be reactive from each team depending on the parent wishes. So if the neonatologist discuss with the parents that actually palliative comfort care is more appropriate for their baby, then that will alter what the obstetric plan is for delivery and monitoring. So this then can be reactive depending on how the conversation goes. And the midwifery involvement is also really important because midwives can listen to the conversation and then help better support parents after the conversation is finished and the neonatologist and obstetrics have left and the midwives are left caring for the mother and the family, allowing them to have an understanding and discuss the conversation that's been taken place. So when should we do the counselling? At the earliest opportunity, really, which allows for information processing, discussion and decision making by parents. Also, these are hard decisions for parents to make and they may want repeated conversations and some time to think about it. It also minimises the effect of labour and medication, which might affect how well the mother can interpret the information and make decisions. Sometimes if a mother's been transferred in, the partner may not be present straight away. So we want to allow time, if possible, for both parents to be present. And again, if time allows to be carried out in the daytime, so mothers aren't woken up in the middle of the night or affected by lack of sleep in order to interpret the information and make any decisions. So how can we prepare for the consultation before we actually go into it? We want to make sure we obtain all the background information so we can think about the risk category and interpret the risk correctly. We want to then also look at the likely outcomes, and as Anda showed you the calculator, we can have a look at that to see how the risk factors may alter the outcomes. We want to make sure a consultation's not disturbed, so no one's coming in the middle to try and do observations or deliver food, etc. We want to make sure we can ensure we can sit at the same level as parents. Quite often in rooms when we go and do counselling, the mother's lying on a bed and the partner may be sitting in the only chair in the room. And then you're left in an awkward situation where you're either standing up looking over the parents or you're trying to kind of half perch on the bed. So ensuring we take a seat with us if there's not enough seats, so we can sit at the same level as parents and have a conversation in a comfortable situation. Making sure we use interpretive services if they're needed and not relying on family members to interpret for other family members, as we can't be sure exactly what information they're relaying. And then what to take. So we want to make sure we have written information to support what we're discussing with parents. Taking a colostrum pack, again, to help support expression of colostrum, if antenatally, if appropriate, or at least as soon as possible after delivery. And thinking about taking a junior colleague if you're more senior, so allow them to observe and learn, or taking a senior colleague if you're more junior in order to help support you with the conversation. So now looking at the how do we give neonatal counselling? So this is a summary table for the different risk categories of a structure of counselling. And for all counselling, whatever the topic that you do in whichever specialty, you can use the same kind of basic structure to help you guide how you do your counselling, and therefore gives you a kind of a fallback to think about if you get a bit stuck in the middle of it and you have a mind blank. If you have a structure in your mind, this allows you to guide it and provide the information in a logical way. So we want a beginning where we do introductions, we establish parental understandings, priorities and concerns, and then we want to move on to providing information, which includes providing a big picture, so a summary, discussing outcomes and risks, problems of prematurity, and looking at the key decisions that have to be made specifically in high-risk counselling. And then thinking about breastfeeding counselling as well, if active management is going for. And then concluding the consultation, summarising, answering questions, providing information and offering follow-up consultations. So we're just going to focus on the high-risk counselling in this session today. So starting at the beginning, we want to first of all obviously introduce ourselves, make sure that the parents know what your role is, and clarifying names of the parents and anyone else that's in the room, but also asking if they have a name for their baby, and if they do, if they're happy for you to use it, which just makes it a bit more personable in the conversation. I also find taking a bit of paper into the conversation and just jotting down names as well just helps you to remember the name, so you're not kind of in that embarrassing situation halfway through where you've forgotten what their baby's name is. Then it's really important parts, which helps to set up the rest of the conversation, really. It's establishing the parents' understanding. So something like, tell me what you understand about what's been happening so far. And do you have any experience of prematurity? Has anyone you known had a baby this early? And what happened with them? This will really help you understand what parents know already and what their experience is. Perhaps they've already had a 25-weeker and they're quite familiar with the neonatal unit, and perhaps they know someone who's had a 32-weeker, so actually think that that their baby did quite well, but obviously 32 weeks versus 22 weeks is very different. So being able to know what is in their mind already. Then exploring parental wishes, fears and expectations. This is really key because we want to know what's concerning parents, what's their main priorities for their babies, which really helps to then set up the rest of the conversation and address any concerns as you go along, which will then help to alleviate any problems that may be presented later on in the line. And making sure you understand any other influences, cultural, family, religious. So for example, you could say, is there anything else you think I should know about your family or your background that would help me understand better about what your thoughts are? So it's important to really tease this out at the beginning to help set you up for the rest of the consultation. So once you've done the beginning section, then you can move on to providing the information. So we then want to start off by just providing a big picture, which is really just a summary of the information we're going to discuss, and allows parents to hear the headlines before the details, but also gives them a kind of a headline of, although their baby is likely to be born, they may, because they're so fragile and so early, they may not actually survive to a point where the neonatal team is able to do anything, and may sadly not survive the labour process. So this big picture just allows you to summarize before you get into more detail, where parents may then start to get overwhelmed by what the information you're providing. So I've just got some videos in the next part of the presentation, which we recorded with the help of Eileen and her team at Health Innovation Oxford and Thames Valley, where Dominic Wilkinson and I take the roles of the neonatal doctors and are having a conversation with some parents who are played by actors. So it just gives you a little snippet of how you may phrase these different sections of the consultation. So this is the first video, which is just an example of how you may approach the beginning of the information, providing the big picture.
So we know that Mia is about 4 months earlier than her due date, and we also know from the scans that you've had that Mia is a lot smaller than an average baby for her age. And the combination of these two mean that Mia is very fragile. And we know that for babies in Mia's situation, because they're so fragile, sometimes the stress of the birthing process is just too great. And sadly, some babies do not survive the birth and pass away or die before they're born.
Okay. Thank you.
Thank you. We do know that with intensive care treatments that we can offer, there is a chance that Mia might be able to survive. It would be a long journey for her, but there is treatment that we can offer for her.
Okay.
We also know from babies in the same situation as Mia that if she does survive, there is a chance that she may go on to develop some problems in the future, including severe disabilities.
Oh, okay.
If it's okay, I'll talk to you now a bit more about what these risks are for Mia,
Yes, please.
and what it might mean for her in the future.
So that there you can see is just that kind of summary at the beginning, and then you can move on to talking in a bit more detail about the outcomes and risks of preterm birth. So as Anda also touched on already, it's important to ascertain what information parents would like to hear and when it comes to discussing outcomes. So for example, when I talked about risk factors for your baby, some parents in the same situation as you want to know statistics and numbers, whereas others prefer a general picture. What do you think would suit you the best? Some parents don't really find figures very useful, so prefer that to have a more general picture, and others prefer this more statistics and numbers. So using this phrasing of some parents, other parents can be really useful throughout the conversation to tell parents, actually, you know, it's normal that some parents prefer this and some parents prefer that. There's no right or wrong, and asking them what would be best for them. If they do like to know statistics, research has actually shown that it's helpful to give this in terms of numbers, e.g. 1 in 4, 1 in 10, instead of percentages, as parents find this easier to interpret than having a percentage given to them. And if they want to know more of a general picture, you can use terms such as high, medium, low risk to describe a risk instead of statistics. So discussing chance of survival with intensive care management, you could use phrasing such as, given what we know about the situation for your baby, we think there's about a 1 in 3 in 10 chance of your baby surviving, which means for every 10 babies treated actively with intensive care in situations like this, 3 would survive, whereas 7 sadly would not. So giving these statistics on both sides, so 3 surviving and 7 sadly not surviving, allows parents to interpret that statistic neutrally and without any framing bias. So without just giving one side of the story, but giving both sides. Again, discussing risk of disability after survival can be quite tricky, as Anders again already touched on. There's not really a simple definition of a poor outcome, and a poor outcome for one family may actually be quite acceptable for another family. So trying to just give parents the facts and not describe it as a poor or positive outcome, but telling them what we could expect allows them to interpret how they feel about that. So, for example, for babies born as early as your son or daughter baby, if they survive, some of them may have serious long-term problems in the future. And for babies like yours, about 1 in 4 of those children who survive may have a very severe long-term disability. For example, they could have severe problems with learning or movement and may mean they need a lot of support and help in the future. Other children born this early may have less severe problems. So you can give just a kind of an overview of what a severe disability might mean for them, and then ask if they want to know some more detail about that. The slide is quite a lot of writing, but actually this slide is just taken from the BAPM framework, where it lists out these suggested phrases about going into a bit more detail about what a severe disability may mean for a preterm baby. And it's important kind of when you're talking about this to say, we can't really say which of these problems your child might have or how they might be. They might have a number of these and have many difficulties, or may only have one, and they might be less severely affected, or they may have none of these at all. And kind of emphasizing we can give an average number as a prediction, but it's really hard to predict what specifically, if they're affected, what they may have, and how, and if they have one or several of these problems. Again, as I said before, trying to adjust the gestational predictions that are provided in the BAPM framework is quite important, as we're using a risk-based approach. And the NICHD calculator does help with this, but just to put in a word of caution that this calculator is from US data, so we do have to interpret the figures from this with some caution, because they may not always be fully applicable to UK data, but it does give us a rough idea of how we can adjust these gestational averages when we're talking to parents. And using these infographics as well can be quite helpful for parents with the dots to say, to kind of show that 4 out of 10 babies may sadly survive, but however 6 out of 10 may therefore survive, and allowing parents to visually see it as you're describing it as well can be quite useful for them. We also want to make sure we provide balanced information, and studies have shown that conveying solely negative information isn't well received, and having that importance of hope, that we do emphasize that it may be that their baby has no problems and they don't have any disabilities. So not just kind of focusing on the negative, but also instilling the hope. And we should try and explore parents' views and values relating to what an acceptable outcome is, because as I said before, one set of parents may find that having a child with a disability is completely acceptable for them, whereas for other parents that may not be acceptable for them, and they couldn't see that within their lives. So here's another video that is just an example of discussing the chances of survival and severe disability.
If it's okay, I'll talk a little bit more about those risks and uncertainties for Mia now.
Okay.
When I talk about these, some parents like to hear about statistics and numbers, and they feel that helps them understand what's in store for their baby. Other parents don't find that helpful and just like to hear about a general picture. What would you think would be most helpful for yourselves?
I think I'd like the statistics.
The statistics?
Yes.
Okay. So we know for babies in the same situation as Mia, at her age and her size, that if we have around 10 babies born like Mia, that 3 of those babies would survive with intensive care treatment. And that means that 7 of those 10 babies sadly would not survive. And we know that for those babies that survive, about 1 in 4 babies that survive will go on to develop severe disabilities in the future. And by that I mean they may, as they grow up, have problems with movement. So they may not be able to walk independently and need to use a wheelchair. They may have problems with communicating, not being able to talk, learning, and they're likely or most definitely going to need help and support throughout their lives. But we know that 3 out of 4 babies who survive like Mia will have no disabilities or a mild or less severe disability.
Okay.
It's very hard to say how Mia may be affected, if at all, at this stage, and it will be something that we will have to see as she grows up, how she may be affected.
Thank you.
How does hearing those numbers make you feel?
It's slightly better than I thought it would be, but it still makes me really sad.
Yeah, it's very understandable. What about thinking about Mia's future and the possibility of her having a disability? How does that make you feel?
We haven't really thought about her future much outside of just trying to get her out of hospital, but we would love and support her no matter what happens to her, because
Of course.
It's also important to discuss with parents the problems of prematurity, and that babies are likely to need a long period of intensive medical care if they were to survive. And if you're in a DGH and they're being transferred to a tertiary unit, or if babies are coming from a DGH and you're in a tertiary unit, it's important to highlight at some point they will be repatriated back to the DGH and have a period of their care in their local hospital. Obviously, there's a huge variety of problems of prematurity affecting most of the organs in the body, and it's a lot of information to go into that and to a lot of detail with parents. So generally, I give a kind of a general overview, informing parents that we know that there are several conditions relating to the different organs in the body that can be affected with prematurity. Our written information pack in Oxford has a lot more detail about all of these problems, which I reference parents to, and which allows them to read it in their own time if they'd like to get a bit more detail. Sometimes it can be good, depending on how parents are receptive to the information, to touch a little bit on some of the earlier problems that parents may come across with their baby. For example, intraventricular hemorrhage, which can happen in the first few days of life, as that's something they may encounter quite soon after the baby has been admitted. So now we've gone over the information to providing, the next sections that we would come up to in the counselling is discussing the key decisions to be made in high-risk counselling. So we want to explain the choices that parents have with regards to perinatal management, and having that shared decision process is vital. So us allowing parents to make that decision by giving them the information and supporting them if they need it. Some parents may be very clear about what decision they want, and some parents may be really unsure and look to us for some guidance. Again, as I mentioned before, using this phrase of some parents, other parents, allows us to present these different management options to parents in a way that it makes it seem like that actually, in situations we've had in the past, some parents have chosen both management options, and therefore there is no right or wrong answer to the decision that they have to make. We also want to make it clear that they don't have to decide straight away if there is time. We also can advise that if they make a decision, it's not set in stone, and they can review it and change their minds at any time until the delivery. We want to provide a bit more information about what the different management plans would entail. So active survival focused care would involve transfer to a tertiary unit, discussing what will happen at delivery, including kind of preterm optimization, possibly support with the breathing, with a breathing tube and attached to a ventilator breathing machine, admission to the neonatal unit, being placed in an incubator, and the procedures that are likely to happen in the first 24 hours, which just allows parents to be prepared for what they can expect after admission. And then palliative comfort focused care, letting parents know that babies are kept comfortable. It's about having cuddles and making memories, but because we're not going to be providing any active managements, their baby will pass away. But also making parents aware that they may not pass away immediately, and they may have some gasping, and they may have some heart rate for a period after delivery. We also want to think about parallel planning, so having the eventuality that a baby is not born in as good a condition as we might expect, and making some plans for what will happen if that is the case, or if there is deterioration after admission. So we've got some 2 more videos here where now Dominic Wilkinson is taking the role of the neonatologist doing the counselling, and the first one is about discussing these key decisions.
That can't have been easy to hear.
No, it wasn't.
Given what we've talked about, there are some decisions that we need to make about how we care for Mia when she comes.
Okay.
When babies come this early, especially when they're extra small, the right thing to do when they first come is not necessarily easy to work out. And the right thing might be different for different families. So for some families that I meet in this situation, the right thing to do, the thing they are very keen for us to try, is when baby comes, if we can, to try the intensive medical treatments that we have to try and keep baby with us. So that means putting a breathing tube in baby's throat, putting baby on a life support machine in intensive care, knowing that the chances are uncertain, but wanting us to see what we can do. For other families, that prospect doesn't feel right. If baby comes this early, and with those chances that I described, other families are not sure that it's right to put baby through that. What we might do in that situation instead is, when baby's born, to hold her, to make sure she's comfortable, not put her through intensive treatments and let her go. I've described two different paths that might not be easy to know which one would be right for Mia and for you, but do you have a feeling? What are your thoughts?
I really want her to survive. I think we should go with intensive care. I want her to come out of this hospital.
What about you, Mark?
I'd want to give her a chance.
Please.
I'd want to try everything we could.
What we might do now is talk a little bit about what it would look like for Mia to have that intensive treatment.
And the next video is looking at parallel planning with active treatment. So in addressing this uncertainty if the baby's not responding to the treatment as we expect.
Sarah, we've talked through some of the things that we're going to try for Mia.
Yeah.
But we don't know how she's going to respond to those treatments. It's probably important that we talk through a few of the different possibilities so you know what might happen.
Okay.
I guess what we're hoping is that Mia's, when she's first born, is going to be alive and as strong as she can be, given that she's going to be very small and quite sick when she is first born. But we're going to hope that she responds to the treatment that we start when in the delivery room to try and stabilise her and get her to intensive care. There are a couple of other possibilities.
Okay.
So it's possible that she might die during labour. It might be too much for her because she's small and so fragile. Or that when she's first born, that actually she doesn't respond to our attempts to keep her with us, to putting a breathing tube down, to trying to breathe for her. In that situation, we're going to try and help her and stabilise her. But if she's not responding to those measures, if her heartbeat stays very low and doesn't pick up, that's a very, very worrying sign. And actually, at that stage, given how small she is and so early, although it would be technically possible for us to do even more intensive measures, pushing on her chest, giving her emergency drugs to try and restart her heart, I'm not sure that would be the right thing to do to put her through that. Does that make any sense?
Yes.
Now, we're going to hope that's not the case, that she does respond to the treatment and that we can get her to the intensive care unit. What happens next, I don't know yet. Sometimes the first couple of days are actually not too bad. We sometimes talk about a honeymoon period for our teeny tiny babies, when things can be quite under control. Other times, right from the start, we can see that things are really against us. We might find that we can't keep her with us, that she doesn't respond to treatment, or she might develop serious complications from being born so early and from the treatment that she's having to have. For example, serious bleeding in her brain or in her lung. those things happen, we'll talk to you, we'll talk together, and we'll try and work out together whether we're still doing the right thing for her, whether it's right to keep trying hard to keep her with us, or whether actually we've reached a point where it might be time to let her go.
Okay.
Does that make any sense?
Yes.
So if the parents decide that active management is the route they'd like to go down, it's also important to address breastfeeding counselling, which will arm parents with the key motivation and knowledge that they need to successfully establish milk supply. It's been shown that even if parents have intention to formula feed, that they are still receptive, and most parents will want to do something to help their baby, so are willing to express milk, at least in the initial period, for the preterm babies. So always taking a colostrum pack with you to give to parents when counselling antenatally is really key, to give them the tools and the information they need to start expressing if they're able to antenatally, but if not, at least within the first few hours after delivery, to get that early colostrum into the babies. So then we're coming to the conclusion of the consultation. So we want to conclude by validating parents' situation as very difficult and their reactions as normal. So we want to make sure that parents are aware that what they're feeling and thinking are all very normal reactions. And we want to reassure that parents that they haven't done anything to cause the preterm birth. A lot of parents feel some guilt about something that they have done to put them in the situation that they're in, and trying to give some reassurance can help to alleviate that anxiety. So asking some questions can help with the conclusion as well. So obviously we want to know if parents have any questions. Asking, do you have any questions, is actually quite a closed question, because it's like a yes, no answer. And a lot of people, when you say, do you have any questions, were like, oh, no questions. So instead you could phrase it like, oh, what would you like to ask, which is much more open and assumes that they have something to ask, and what is it? So this really invites parents to ask something that's on their mind, or think about really what the questions they have. Also, what else would you like to know at this stage, to make sure that there's nothing that they had hoped to gain from the consultation that you've missed, and reassuring them that it is a lot to take in, and if there's anything that they want you to talk about again or go over again, then you're happy to do that. Also, parents may want some time to think about what you've said and to take it in, and offering a chance to repeat, to come back and repeat stuff, or go over things again, especially if a partner's not been able to be there, or they want other family members present to hear what you have to say. Then offering that can be quite useful, obviously, if time allows, before delivery. So we want to make sure we summarise the consultation and management plan that has provisionally been agreed. So it's important that parents know that although a management plan may have been agreed, they have able to change their mind at any point, or request to discuss again. And if parents, as I said, if parents want time to consider the options, then agree a time to meet them again. Making sure you give parents a written information sheet, so that you've taken along with you to reference and to any extra information that you want to give, but felt that you didn't want to overwhelm them with information, and just for something that they can refer back to as well. If it's possible and time allows, and inviting parents to visit the unit is really helpful, because it just helps parents prepare for the environment that they're going to be coming into with their baby, as it can be quite overwhelming with all the incubators and the beeping and the hustle and bustle if they've not seen a neonatal unit before. And quite a lot of units are now developing virtual tours as well, which you can give a link to parents so they can, even if the mum is not well enough to move to the neonatal unit to visit in person, they can at least see online to give them some idea of what to expect after their baby's been admitted. Thinking about the high risk comfort care option, if parents do indicate they want this option, it's really important to highlight to parents that although they've chosen comfort care at present, the risk may change as the situation changes. So, for example, if they've only had one dose of steroids at present, or they may then have a further dose of steroids. And if delivery doesn't happen and the gestation increases, obviously then the risk is going to change and the outcomes are going to get better. And therefore, as the gestation increases, it's important to discuss with parents that therefore it may change their view on what is best for their baby and their family if actually the outcomes start to change and improve to a degree. So making sure that you put a clear plan for follow-up discussion in place if delivery does not happen and the risk is likely to change, whether it's a few days or a week's time, but having that plan in place so it's not just stuck at a comfort care level, even if the baby then progresses up the gestational weeks. It's also really important about documentation. Communication and the agreed management plan should be documented in the clinical records. And we also need to highlight that the plan will be revised if it is comfort care, that if the pregnancy continues and the risk factors change, and also if the plan will be revised depending on the condition of the baby at birth. If they want an assessment at birth and limitations on how far the resuscitation may progress if appropriate. If an in utero transfer is being undertaken and a local neonatal team have already started the counselling process with parents, it's really important that these are really clearly documented so the receiving centre are clear about what's already been discussed and what the parents have already initially indicated. So it's clear for all teams, and also so there's not kind of a mismatch of information that parents then receive from different teams. This is just an example of a documentation pro forma we used to use in Oxford. We have actually now moved to online documentation on maternal badgernet, but we try and include all this information. It's quite a useful tool to have from when you're documenting to make sure you include all the important information and a clear summary of the discussion and what the calculated risk category was, and also what specific estimates of survival were given and severe disability to parents that were given. So again, if someone comes from in the future, a different person to do some counselling, it's really clear about what has already been said to the parents, and therefore you're not giving conflicting information unintentionally. So as I mentioned at the beginning, these webinars are kind of part of a bigger counselling, preterm antenatal counselling education programme. And we have, over the last few years, have been developing a one-day workshop, which has evolved into a multidisciplinary workshop with neonatologists or paediatricians, obstetricians and midwives. And it's a day session, which is face-to-face, that has detailed sessions on the BAPM framework, so more detail similar to what Anda presented in the first burst of the webinar. We also have a psychologist session where they think about the psychological approach to counselling, where they have interviewed parents about first-hand perspective of their experience of counselling and how we can pull this apart to look at the different responses to receiving difficult information, and then how we can address that as the people giving the counselling to help make it easier for parents to understand and retain the information. We also have sessions from our obstetrician preterm specialist about obstetric preterm counselling on what specifically would be included in that side of the counselling. Again, similar to the session I've just provided, but with some more detail and more videos about neonatal counselling. And then in the afternoon, we get in some actors to play parents, and we have role play sessions where each of the participants are able to have a go at providing counselling in a safe space and getting some feedback from the faculty to how to improve it for when they're providing it in real life. And the sessions we have done so far have got some really positive feedback about how much it increases confidence in providing counselling in the clinical situation for the participants involved. So we've got 2 dates fixed for the Thames Valley and Wessex region. So one is on July the 18th for Wessex, and we've got October the 15th for Thames Valley, which is in Oxford. So we will be circulating details soon about how to register interest and how about securing a place on those courses. So just to summarise, we have talked about the BAPM framework and how we can assess the risk for different cases, looking at preterm antenatal counselling, and then how this then influences how you will structure your counselling conversation that you're having with parents, whether it's moderate, high or extremely high risk. But actually, whichever risk category and whichever counselling you're giving within your speciality, you would still have a same basic structure. And having this in mind allows you then to have a logical progression when you're having these conversations with parents, and allows you to have something to fall back on if you're finding it quite stressful and a bit stuck of where to go next. If you have this in your mind, it just gives you that next step of where to progress the conversation to. So thank you very much for listening, and I hope that has been useful. And I think we are now able to take some questions. And obviously we've got Dominic's webinar in next week, and he's doing 2 webinars which are going to be exactly the same. So don't feel you need to dial into both of them, but he will also be able to answer questions from his webinar, and he's obviously very experienced as well in this area with his Professor of Medical Ethics at the university. So I will stop sharing now. And
brilliant. Katherine and Anda, thank you so much for covering so much in that session. I'm going to just direct us to the Q&A. And Tara, if you're, let's start with Jasmine. Anda has answered the question, but actually, Jasmine, we'll enable your camera. And if you'd like to come on, then we can just maybe discuss that question in a little bit more detail. And then if we are able to move to Hemant, who's put a detailed question in from Dartford and Gravesend, we could enable Hemant's camera as well. For everybody else, if you just pop your hands up or pop the question in the Q&A, then we can make this a bit more interactive. Okay, Tara?
I think that, yeah.
Sorry, Eileen, I just need to find the right person.
I see. Okay.
You said to me, Jasmine, so I just need to.
That's okay. Don't worry. It's not a problem. So just taking that question, you were able to read it, Katherine?
Yep. So Jasmine has asked, with regards to statistical outcomes, are these based on babies being born within a tertiary hospital? It's well known that outcomes differ if they're born in an EGH and the baby has additional complications of postnatal transfer. Is there any data to support these conversations? So I think the statistics that are in the BAPM infographic in the framework are just the average for all babies born at that gestation, and which is why we were saying that actually you need to make sure you adjust those statistics when you're talking to parents in relation to the different risk factors that each of the parents, the families have. So that's why using the calculator, the NICHD calculator, can be useful in order to adjust those statistics or give you an idea of how they may adjust. So quite often, if I'm talking to parents and showing them the BAPM infographic, I'll say that although you're at 24 weeks gestation, because of X, Y, and Z extra risks that your baby has, and one of those may be that your baby is in a district general hospital, your baby, if they were to be born right now, would be more like a, for example, a 22-week gestation, but you have to adjust slightly depending on what the different risk factors are. So then you can show parents actually what the statistics may be for their baby, given all of the whole picture, not just the gestation.
Yeah. I've included in the Q&A session this article, link to the article about Epicure 2, specifically data, and it just sort of tells you that there was a 56% of babies in that study were born in maternity level 3 unit, and 34 level 2, and 10% were born in settings outside intensive care. So if you want to know the more statistical approach, not that you need to tell that to the parents, but if you want to have your own background information, the article is CC'd in. But the BAPM statistics, as Katherine said, has taken that into account, so you can surely tell them those statistics from the BAPM framework. Yeah.
Thank you.
Next.
Anda, thank you. Katherine, can you deal with the next question from Hemant, please? It's quite long.
Yeah.
If you could pick it up.
Hemant has asked, how do you approach a situation where there are not in imminent labour but extremely high risk? So transfer to a tertiary maternity unit is planned, and comfort care is still the best option. But now there's increased expectations for parents due to the transfer, although the plan stays the same for a few days. I would have thought everyday discussion is needed when in tertiary. Can the tertiary centre refuse transfer when extremely high risk but not in active labour? I would think transfer is still best option, as things may change in the next few days. So if it's extremely high risk and therefore the management plan would be for comfort care, it wouldn't necessarily mean a lady has to be transferred to the tertiary units at that point, because if the baby was going to be delivered, then it's the neonatal team is not going to intervene, and actually you're transferring a lady to a centre which could potentially be hundreds of miles from their home and their support network, and actually is that the best situation for that lady to be on? And you're taking up a tertiary bed when actually the baby's not going to have active management. It's therefore then when the situation starts to change, if delivery's not happened and you're getting more into a high risk and parents do want active management, that's when the transfer can then happen to the tertiary centre.
I think it's important to explain this to the parents, that situation will be fluid and they need to be aware. And again, if they either then rediscuss with their community midwives and then get more if they want a more consultation and rediscussion with probably the obstetricians or neonatologists, that then can be organized. But as Katherine said, yeah, it's we don't want to separate, where they obviously would be more beneficial to have family around for support, and particularly in comfort care cases. But if they are transferred to NICU, so tertiary centre, and they are high risk, then we do review cases on a daily or every kind of 48-hourly basis, and a consultant neonatologist do go and speak to these mothers and make sure that actually the plan is the same or plan has changed, So, and we have our own kind of handover list where we write these updated plans in. So I think the right thing is to have a repeat consultations when they are in tertiary centre at this high risk gestation.
Thank you, Anda.
Yeah, and even I think they were saying, Hemant was saying, do they need kind of daily discussions? If it is kind of on the borderline of extremely high risk and soon going to be going into more of a high risk category, then it may be that actually it is kind of a daily assessment and seeing, what the other factors are as well in terms of growth and the sex of the baby, all the other risk factors, Dopplers and other things that we take into account, but aren't necessarily part of the BAPM risk assessment at the moment.
So if we could take the question from I think it's Arya, forgive me, my pronunciation isn't great, but the question is related to the BAPM framework, cover up to 27 weeks. Is it okay to opt for comfort care for higher gestations, such as 26 weeks, if parents do not want to resuscitate? And what about rights of baby and legalities?
So this
That's
is
a good
always
question for Dominic.
tricky question, and I think that might be one that we say for Dominic later on.
Yeah.
But as far as I know, that the BAPM framework is up to 26 weeks to 27 weeks,
Yeah.
and if a baby's deemed to be moderate or above that gestation, then they're born, and we have to then act in the best interests of that baby and do what we feel is best for that baby in terms of resuscitations and for the rights of the baby. But again, that'd be something we can discuss with Dominic in the next webinar, as this is really his area of expertise.
And Joe likes to perform up at the antenatal counselling documentation. Can this be shared? So can you guys just cover off? We're going to record this and share the recording and obviously the resources, but for the particular performers.
Yes, we have a Word copy, so I can provide that, Eileen. You can distribute
Perfect.
it.
Lovely. So there's a question from Joe. Hi, Joe from Frimley. Do you encourage partners, dad, to witness stabilization resuscitation?
Yeah, they're
yes,
there in a room.
yeah. So we most of the time that when ladies are delivering, they have their birthing partner, dad or partner, to be in the room with them. And if we are stabilizing and resuscitating a baby, then we do encourage them to witness. And most of the time, they're just a meter away, so they are there witnessing. Depending on what the staffing level is like, if it's in the middle of the night, obviously we don't always have spare members of staff, but wherever possible, we do try and allocate a member of staff who has experience and knows what's happening with the resuscitation, to stand with the parents and just to kind of describe what's going on. So parents are therefore kind of aware of the processes, because when the team's involved in the resuscitation or stabilization, it's not always easy at that point for that team to kind of take focus off the baby and discuss with parents. But if there's no spare member of staff available to do that, as soon as we're in a stable place, quite often the person that's having the overview, the team leader, will then step away from the resuscitation or stabilization and update the parents to what's happening. And as much as possible, we try and give what we call birthday cuddles to babies, even those that are ventilated, before we transfer them to the neonatal unit. So parents have that brief time to hold the baby and take some photos and make memories before they're transferred.
Yeah. And it's something you can also approach in antenatal counselling or on the day of the delivery when you go in. So as a team, you can reintroduce, because obviously counselling might have been done by somebody else. And then when you go in, you can just say that, I'll be today, if the baby's born between these hours, then I'll come and support. And then, you can stand here, or you can encourage dad to take photos, and then he can come closer. So it's something as a, so they're not a different face when you go into the room. So, but it's important to mention.
So a question from Alexandra Brooks asking about at what point should a decision to offer comfort care only be revisited after delivery, especially if not at a tertiary centre?
I assume Alexandra means if a baby's born, if a baby looks like they're in a better condition than expected and they're alive. I mean, if a baby is in a high risk, where the risks are so high that the parents have opted for comfort care. As I said in my talk, their baby may have some signs of life and gasping and some heart rate for a period after the delivery, but they're unlikely to, survive for a long period. And even, the parents have had that decision that they want to have comfort care. obviously it's a difficult situation if the parents are kind of undecided but prefer to have comfort care, but that, you know, it may be in terms of what I was discussing, and Dominic showed an example, but kind of for the other way, where active management was decided, but actually there was parallel planning for when to go into kind of more of a comfort care. You may also want to have kind of parallel planning for comfort care, but turning it into active care if a baby looks like they're kind of got strong signs of life after delivery. So it's quite important probably to plan for that prior to delivery. But you know, if it's a 22 plus 1 weeker, you know, they're not going to survive for really a period of time to transfer into that situation.
Okay, so moving on to Rosalie from Merseyside. She's asking about, since a lot of preterm deliveries are an emergency situation, what is the minimum information you think can be given in that situation?
So it really depends how much time you have and what the risk category is. So, you know, it depends what, you know, on the time frame, but I guess what you really want to ascertain from parents is trying to give them enough information. You know, if you're in a high risk category, giving them enough information in terms of the, you know, the outcomes and the problems with prematurity, for them to make a decision whether they want active management or comfort care management. And you can give that in a relatively short space of time if you're able to summarize and kind of to ascertain from them what they'd like. But you're right that sometimes we don't have that time in deliveries where women just present and they just deliver, and we don't even really have time to say anything to parents. And in that case, probably the best situation would be to embark on life-sustaining treatment, and as early as possible for someone from the team to speak to parents and try and ascertain what their views are, because it may be that they have extremely strong views. They don't want resuscitation, and therefore then you can step back with what you're doing. But those are quite difficult situations where there isn't time to fully have this full conversation.
Anda and Katherine, I just want to go back to Alexandra for a moment, because he's just made a comment that locally they had an extremely distressing situation where the parents had been discharged from the tertiary centre with a plan for comfort care, and then contacted the tertiary NICU directly while on the level 2's delivery suite.
Yeah. Sounds familiar case.
Yeah, I think if this is a
we've
local
had
case,
a similar case as well, and I think and that's why it's important is to make sure that parents understand what is the plan, that they feed back to you. Do they understand what is this treatment plan? So I think we've had a case where the counselling was, and then baby was in extremely high risk category. However, the plan was for us to revisit counselling in 1 or 2 weeks time if she doesn't go in a labour or at the time of labour. And from our end, it felt that it was very clearly documented and it was absolutely fine. This mum then progressed to pregnancy of just over 26 weeks. And the impression in the local unit was that they still need a comfort care. However, the situation has changed and baby was born in really robust conditions, and therefore actually providing a survival-based approach was absolutely fine. And actually the 2-week revisit or week revisit recounselling session didn't happen because she kind of went into labour beforehand. So I think it's important, again, when we plan a care, as we said, from high risk to the moderate risk and extreme risk, the situation can be fluid. You know, yes, we plan for comfort care when baby's born in really poor condition, and that is the best decision. But actually, you need to counsel the babies may be unexpectedly born in better condition than we predict, and therefore active management is appropriate for this baby. And in our case, I'm sure Alexandra, in your similar cases, yes, it's baby survived and survived well. But yeah, so then it's transferring postnatally the delivery suite needs to inform the local neonatal team that this mum has come in and currently says the palliative plan. Is that still true? Can they come and re-counsel? You know, it needs to be a little bit more proactivity in before she delivers, if there's opportunity to speak to them. But if baby delivers and shows signs of life and is good signs of life, then we have obligations to treat this baby. Catherine, is that something that you kind of want to say?
I think it's probably similar case or the same case as what we had Anda was talking about. And I think, as I was emphasising, that it's really important when comfort care is decided that plans are made in place to revisit that, and especially with increasing gestation. So it may be high risk and they've gone for comfort care, but actually when you're progressing to kind of outside the framework to 26 plus weeks, then actually you're probably entering to more of the moderate risk, and therefore the kind of comfort care approach wouldn't be applicable. So really having robust, clear plans of when to revisit the decision about comfort care and changing it with increasing gestation, and that may be within a few days or it may be within a week, but making sure that all teams are involved, the local, especially if a lady's being transferred back to the local hospital for care, ensuring that is revisited, so if delivery does not happen. So clear communication is key, I think, in this.
Thank you. I'm trying to get as many questions covered for us as possible. I want to pick up a question in the chat asking that the comment is, challenges still remain with those cases where the family are undecided, and how do we go about when to advocate for optimization?
So obviously parents sometimes don't have a clear mind about what is important, you know, what the decision they'd like, and I think that's really important in there. What I was trying to emphasize in the webinar is about trying to find out what's important for them, what concerns they are, what their thoughts are about having a baby with, you know, possibility of disabilities, and once you've kind of elicited all those concerns and got an idea of what their thoughts and feelings are about the outcomes you're discussing, it can then be able to offer them support about what they feel would be right for them and their family. But obviously but this is why this kind of middle zone exists in the high risk category, because it isn't clear, you know, there's not really an ethical one way or another. It's what we call the grey zone. You know, where the extremely high risk cases, it's really clear that comfort care is in the best interest, and for the moderate risk, it's really clear that active care is in the best interest. But in this middle grey zone, it's not clear, and therefore that's why it's really important to try and help parents decide, because we don't want our views, our personal views or professional views, to kind of influence parents, because ultimately it has to be a decision that we can help them with, but it is their decision, because they're the ones that are having to, you know, it's their child, they're going to have the responsibility and care for the rest of their baby's life.
So how do you coordinate multidisciplinary counselling parents with all specialists at one time? It does sound quite ambitious, doesn't it?
So it is tricky, but it is doable. So obviously the midwife looking after the lady is obviously quite often is available most of the time, and then the neonatologist will be coming to normally wherever the lady is, on the postnatal ward or the observation unit, and trying to then coordinate with the obstetrician. But it is doable to do, and I think it's really key and important for families to have all of those wherever possible. Obviously it's not always possible, because, you know, the obstetrician may be attending an emergency, but as much as possible, at least the midwife and the neonatologist, but having the obstetrician is really helpful for parents and for the whole consultation where possible.
So I think if we take one final question, a more technical one, cardiac compression and adrenaline as part of resuscitation is appropriate beyond 4th gestation?
So I think in the framework, it doesn't give a specific cutoff for not doing compressions and adrenaline. It's very much case specific. Obviously, when, you know, if it's a borderline extremely high to high risk case, then probably chest compressions and adrenaline would not be the appropriate, as it's unlikely to work for those babies. But you know, if you're getting into a 22 plus 6 or 23 plus, you know, a baby which is actually moved up to be in the middle of the high risk category, it may be appropriate to do a brief period of chest compressions and adrenaline. And I think the research that Dominic has presented before shows that actually the outcomes can be favourable with doing chest compressions, and condition at birth is not necessarily related to longer term outcomes. So I think it is case specific, and I would probably say borderline extremely high to high risk, probably not so appropriate. But as you're moving in towards the high risk category, that could become more appropriate, but also probably depends on other factors as well, influencing the baby and the situation of the preterm birth as well.
So still on that theme, is there a straightforward answer in terms of offering optimization, so the steroids, max sulfate, for high risk cases? I'm assuming extreme high risk not offered, moderate offered, and again, thinking if delivery does not happen in a few days, then category may change, so better to offer. So I think you probably covered it more or less.
Yeah, I mean,
I think we covered that. So it's really case specific. So I think that's why we need to be conveying the information to the parents in a way they can understand and make their assessments. It's almost like also like the for these extremes of prematurity, you know, 22, 23 weeks. It's almost like if we're not going to offer, we're not going to know what the outcome is going to be for those babies. So, but the parents need to understand, you know, that currently, you know, outcomes for 22 weekers is similar to 23 weekers. And actually, of the recent paper that was published by Cheryl Battersby's group from London, where they revisited what is an uptake of this 2019 framework, and the units are providing more care for these 22 weekers. And actually, that has increased threefold now from previous BAPM guidelines where they didn't offer management for 22 weekers. So, and you know, I think if there is a extreme preterm but with favorable risk factors, we probably should be offering active management. But again, that is whether that is in best interest of this family, and they need to decide that amongst them. We shouldn't influence their decisions of how I feel, you know, that whether we should or shouldn't. So Katherine will add on to that.
No, I think that's a great answer, and I don't think nothing really more to add.
Yeah.
Katherine and Anda, thank you so much, and thanks to all the participants for the questions and for taking the time out of your busy schedules to come and join us today. So we would be so grateful and appreciative if you would complete the feedback, because it will help us to refine webinars and these kind of sessions as we go forwards. So the details are in the chat regarding the next webinar. We'll pick up any questions. I see there's some person that is worried about having a registration problem. We will pick that up and we will come back to you. We will share the recording, and Katherine will send me the Word document, and I'll send that with the resources. And I think that's everything. Anything final from Katherine?
Yeah, I think that question about ethics we can ask Dominic to answer, so we can forward to him for the next webinar series. So that would be great. So yeah. Okay,
perfect. And I just want to acknowledge and thank Tara and Alice, who have been just instrumental in making sure that we've been tech-free today and helping us to make sure this has run so smoothly. Thank you both very much. So we're going to stop recording, and I wish you all a happy weekend.